Skin infections come in two flavors as far as we're concerned, bacterial and viral. Let's start with bacterial infections. These are actually very board relevant, particularly because Staph aureus and Strep pyogens cause the majority of bacterial skin infections, which can make for difficult diagnoses if you don't try and keep them straight. We'll provide the classic vignettes for these infections. The first is impetigo, which is a very superficial skin infection, usually caused by either Staph aureus or Strep pyogens. Are you surprised these organisms cause this disease? Well, don't be, since they are part of a normal skin flora. It's incredibly infectious. The classic location is on the face, likely on the chin, with some of the lesions rupturing, leaving a honey-colored crust on top, a virtually pathognomonic buzzword for you to remember. Now, does this lesion scar? No, it's a superficial infection. Flash quiz. What bug is most likely the cause of impetigo? Staph aureus. Now, cellulitis is a very common disease and is probably the start of a spectrum of diseases. Basically, you should think about cellulitis as an acute, painful, red, hot, spreading infection of the dermis and subcutaneous tissues. The same bugs, Strep pyogens and Staph aureus, are implicated here as well. Usually, the patient has a break in the skin from minor trauma. However, you should be wary of the presenting scenario. For example, what might you expect if the skin is burned? Very good, Pseudomonas. Erysipelas is maybe my most favorite word that I learned in medical school. Erysipelas. Say it 5 times fast. Anyway, it's a Strep pyogens infection to the upper dermis and the lymphatics that presents with a well-defined, demarcated area. What other skin condition affects the dermis and lymphatics? That's right, hives. Here comes another skin infection you've definitely heard of, an abscess. Now, what is an abscess? It's a collection of pus in the deeper layers of the skin, and usually it's walled off. And what's the bug? You bet, Staph aureus, and most likely MRSA. So what's on the severe end of the cellulitis spectrum? Necrotizing fasciitis, affectionately abbreviated to neck fash, a much deeper injury that is much more serious clinically. Now, what's the bug here? Strep pyogens, but also by other flesh-eating anaerobic bacteria. The classic description is the finding of crepitus on physical exam, a type of crackling sound which is quite literally the sound made by rapidly moving bubbles of gas that is formed underneath the skin. This gas comes from methane and carbon dioxide produced by the underlying infection. The clinical scenario will either include a post-surgical patient or a patient with a skin infection that appears to be worsening incredibly rapidly. There may be some blood-filled blisters that form quickly, or a gray discharge from the surgical site. Would you expect these dusky gray edges to be painful? Actually, no, because the flesh is already dead. Now, what should you do? You need to get them to an OR and debride. Flash quiz. What is crepitus? It's the crackling sound on physical exam, which is the sound of moving bubbles beneath the skin. The next skin lesion is actually a syndrome called staphylococcal scalded skin syndrome. Do you recall this syndrome from the infectious disease chapter? Here, an exotoxin that is released by Staph aureus destroys the attachments between keratinocytes and the granulosum layer of the epidermis. Patients develop a generalized erythematous rash with loss of the layers above the granulosum. Classically, this disease is thought to happen in newborns and children. 2 things help to confirm the diagnosis. First, you should expect that since it's a diffuse disease, there will be some systemic signs, like fever. These patients, usually kids or newborns, are sick. They may even have underlying renal insufficiency. Does scalded skin syndrome leave scars? No, it heals completely because it's only affecting the superficial layers. Let's move on to a handful of viral skin infections. The first is herpes, caused by HSV1 and HSV2. An outbreak can occur on mucosal or skin surfaces and is a very painful vesicular rash. Molluscum contagiosum is a viral skin infection you'll most likely see on your pediatric rotation. These lesions show up in crops of umbilicated papules caused by the pox virus. The more children pick and scratch at these, the more they spread by autoinoculation. Totally benign infection. Varicella zoster virus causes both chickenpox and zoster, or shingles. These crops of vesicles invariably progress to crusted, itchy lesions. Zoster will always be in a dermatomal distribution and won't cross the midline, a key clue when you look at an image. The final infectious skin disorder we'll discuss is hairy leukoplakia, which classically appears in the mouth, even more commonly on the side of the tongue. Now, what else would be on your differential for a white tongue lesion? Good, thrush. The clinical distinction is made when you try to scrape it off. Thrush comes off, while leukoplakia doesn't, even though it may appear as it should. Do you remember from the micro lecture what virus causes this disease? This lesion occurs as a result of EBV infection, usually, and is often a sign of underlying immunocompromise, such as an HIV or AIDS. Let's go over the information on blistering skin disorders. The first two we've actually talked about to some degree when we were discussing the desmosome and hemidesmosomes. IgG antibodies against the desmosomes give which disease? Good, pemphigus vulgaris. You'll need to be able to distinguish pemphigus vulgaris from bullous pemphigoid on the exam. This causes segments of epidermis to lift off away from one another, which leads to the formation of intraepidermal bulla. Do you remember the term for this skin finding? Acantholysis, and it can be pretty severe. On immunofluorescence, you'll see a net-like pattern because the antibodies can be found throughout the epidermal layers between keratinocytes. Do you remember where the hemidesmosomes are? They're located on the basal layer of the epidermis. What might you expect on immunofluorescence of bullous pemphigoid? Well, you'd expect a line instead of a net. This means when the hemidesmosomes are destroyed, the epidermal layer lifts off the dermal layer in one untouched piece. On your exam, tense blisters are more likely to indicate bullous pemphigoid, whereas flaccid intraepidermal bulla are seen with pemphigus vulgaris. Also, a Nikolsky sign, or easy separation of the skin with gentle stroking, is seen in pemphigus vulgaris as well. If the skin doesn't separate with a gentle touch, it's more likely to be bullous pemphigoid. Another distinction is that pemphigus vulgaris will affect the skin and oral mucosa, while bullous pemphigoid only affects the skin and not the oral mucosa. Flash quiz. What is Nikolsky sign? Skin that separates with application of a gentle tension. The next blistering skin disease is dermatitis herpetiformis. When you think about the word, it quite literally is skin inflammation that appears like a herpes infection. If you look at this under immunofluorescence, the appearance is that of IgA at the tip of dermal papilla, which causes the tips of the papilla to light up like snowcaps on mountains. The papules and vesicles are itchy and are usually found on the extensor surfaces of the skin. What is this particular skin manifestation associated with? Good, celiac disease, which in some cases may precede the appearance of GI symptoms. Do you remember what type of hypersensitivity reaction this represents? It's a type 3 hypersensitivity reaction due to the deposition of IgA immune complexes. The final blistering skin diseases are erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis, which probably shouldn't be thought of as a classically blistering diseases. Erythema multiforme and Stevens-Johnson's are the two ends of a spectrum that occur as a result of drug reactions, much like the spectrum of cellulitis and necrotizing fasciitis. Toxic epidermal necrolysis is severe Stevens-Johnson syndrome that affects greater than 30% of the body. Erythema multiforme is the most benign reaction. EM classically shows a number of different lesions, usually with macules, papules, and vesicles, and some targetoid lesions, a classic finding. These targets have multiple rings and a dusky center. Many drugs can cause EM, including sulfa drugs, beta-lactams, and phenytoin. Additionally, you may see EM as a result of certain infections, like Mycoplasma and HSV, but this is a less common association made on the board exams. The other even less common possibility is EM that results from cancer or autoimmune disease. It's worthwhile to know these associations exist, but you should keep EM strongly linked to the adverse drug reactions for the purposes of the boards. Stevens-Johnson syndrome, in contrast to EM, has more concerning skin findings, usually including bulla with necrotic areas, particularly orally, and is found along with systemic signs like fever. What is it called if more than 30% of the skin is involved? Well, that's toxic epidermal necrolysis. This is life-threatening, and the skin is sloughing off. What is the common cause of erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis? Drug reaction.